Evening, everyone, and welcome to this evening's Fireside Chat. It's going to be our 174th Fireside Chat in this webinar series, and it's going to be an interesting topic today. My name is Dr. Yuri. I'll be your moderator for this session, and our topic for this evening is going to be on atypical HUS, hemolytic uremic syndrome, from evidence to clinical practice. Our guest speaker for this evening is Dr. Hormaz Dastoor, who currently serves as a nephrology consultant at Seha Kidney Care and Sheikh Shakhbout Medical City. He finished his training in nephrology at Columbia, Presbyterian, and Cornell Hospital in New York City. His main interests include general nephrology, glomerulonephritis, electrolyte disorders, and sodium kinetics. So Dr. Dastoor is not a stranger to us. I think for this audience, he's been time and again coming to present very enlightening topics. I think we have had a topic from him. I think if I remember correctly, it was on ANCA, glomerulonephritis. We also discussed a bit on hyponatremia, among other topics. And again, to this evening, we are looking forward to this other interesting topic on atypical HUS. Over to you, Dr. Dastoor.
Thank you very much. So this is an upcoming topic, AHUS. And as I'll show you, there are a lot of new treatments coming up. But I think the first step in AHUS is diagnosing the cases of HUS. So before, I think where we physicians make a mistake is we start looking for TTP and AHUS, but I think what we should basically be looking at clinically is a picture of what is called thrombotic microangiopathy. And thrombotic microangiopathy, as the name suggests, is characterized by thrombotic lesions, which are basically clots which form in the small blood vessels, that is mainly the capillaries and arterioles, and they involve multiple organs. So these organs undergo ischemia and eventual organ damage. Now, TMA as such is pathologically characterized by damage of the endothelial cells in the microvasculature. Now, regardless of the etiology of this endothelial damage, the net result from this endothelial damage is accumulation of a lot of platelets, thrombocytes, fibrin, the development of a fibrin clot, which basically causes ischemia and progressive organ damage. So our role as physicians is when we identify this TMA-like process, a differential diagnosis should go in our mind, and we need to look at the causes of TMA. Now, TMA as such presents, how does TMA present if we look at the blood picture and the clinical picture? So TMA is characterized by three basic characteristics. Number one, the presence of thrombocytopenia. So if you have a patient who presents with a platelet count of less than 150,000 or greater than 25% decrease from the baseline, and clinical evidence of MAHA. MAHA is microangiopathic hemolytic anemia. And it is different from autoimmune hemolytic anemia because in autoimmune hemolytic anemia, you have an antibody which is causing the hemolytic anemia. Whereas in MAHA, or microangiopathic hemolytic anemia, it is an antibody negative hemolytic anemia. But regardless, you see features of hemolysis, that is the presence of schistocytes, elevated LDH, elevated bilirubin, decrease in hemoglobin, and haptoglobin. So whenever I see a clinical picture of where the labs show thrombocytopenia and evidence of MAHA process, then my mind shifts that maybe histologically this patient is having a TMA process characterized by hematologic abnormalities, which include thrombocytopenia and MAHA, and you need an evidence of an organ damage. So for nephrologists, we mainly focus on renal impairment, which can be either elevated serum creatinine, elevated blood pressure, active urinary sediment, or in the most severe cases, severe anuria. Quite commonly with TMA, you see neurologic symptoms, confusion, seizures. We have also seen GI complaints and pulmonary complaints. So there's a plethora of symptoms that can happen with a TMA-like process. So as I suggested, once again, to clarify, if on a blood picture you see thrombocytopenia, MAHA, and evidence of some end organ damage, then that process is called TMA. The three main diseases which clinically present as TMA are, number one, TTP, number two, which we all know is STAC or Shiga toxin associated HUS, and the third one, which is very uncommon, but now with awareness, we are seeing more and more of it, and that is called atypical HUS. So here is what I usually use as my differential diagnosis for a TMA presentation. So if you have somebody who presents with TMA characterized by thrombocytopenia and MAHA, you first need to rule out TTP. Now, at least in our hospital, we have ADAM TS13 available to us within 48 hours. So if ADAM TS13 activity is less than 10%, then it goes in favor of TTP. Now, in some countries, I think especially in Africa, if you do not have ADAM TS13, then you can use what is called the plasmic score. I haven't shown it here, but you just plug in the plasmic score app. If the plasmic score is greater than 5, then there is more than 80% chance or 90% chance that your patient has TTP. If your plasmic score is 5 or less, then probably you need to look at other causes of TMA besides TTP. So once we have ruled out TTP, the next step is to rule out this, the most common cause of HUS, which is Shiga toxin associated E. coli. And this is usually done, at least in our hospital, by getting stool cultures and by doing PCR on the stools, which usually shows us Shiga toxin associated E. coli. Once we have that confirmation, we don't look for other causes usually. But if you don't have a Shiga toxin, E. coli, HUS, and you don't have TTP, then you have to shift your focus to what is called atypical HUS. Now, atypical HUS can be caused by various diseases or different etiologies, such as malignant hypertension, malignancy, transplantation, bone marrow transplant, drug-induced AHUS, autoimmune AHUS, which can be caused by lupus or other collagen vascular diseases. Infections are quite common, pneumococcal infections, CMV infections, HIV infections. And we have also seen cases of vitamin B12 deficiency or homocysteine, increase in homocysteine. Those can cause AHUS. And if you rule out all of these causes, then you can definitely say that your patient has what is called primary AHUS, which is basically a complement disorder. It is caused by dysregulation in the complement system, which is causing a damage to the endothelial cells and thus starts the process of TMA. So you have a big differential diagnosis, but I think it's very helpful to remember this slide and how to proceed stepwise in your differential diagnosis. Whenever whenever you have a patient who presents with TMA. Now, why do we call it atypical AHUS? We call it atypical HUS because the typical HUS is what we have learned from our school days, where typical HUS is the Shiga toxin associated HUS, and anything which is not TTP or is not Shiga toxin associated belongs in the group of atypical HUS, where, as I told you once again before, you need to go through that differential diagnosis of viruses, pregnancy, malignant hypertension. And if you have ruled out those causes, then you can think about primary atypical AHUS. Now, atypical AHUS, now I'm talking about primary atypical AHUS, which is the complement mediated disease, is a very rare disease. So in the United States, the incidence of the disease is only about 2 cases per million per year. In Europe, the incidence is less. Okay, as I told you before, it usually presents as a TMA picture characterized by thrombocytopenia and non-immune mediated hemolytic anemia. There is no specific diagnostic test to definitely diagnose AHUS. Therefore, the diagnosis of AHUS is based upon clinical criteria and your clinical judgment. And atypical HUS is a very common genetic problem, but it needs a trigger, and in the absence of trigger, it is a very rare disease. Here, once again, I can show you it is associated with a genetic deficiency of complement regulatory proteins. It can happen at any age. It is characterized by a genetic deficiency. These genetic mutations can be present in up to 10% of the population. So you may ask me, well, if it's in 10% of the population, why is it such a rare disease? Because the disease does not manifest itself phenotypically. The disease needs a trigger. I'll show you certain triggers. So in the presence of the trigger, the disease can manifest itself. The disease also needs a threshold to manifest itself. So if you have a TMA-like process which is initiated but does not reach a certain threshold, then it won't be clinically manifested or self-sustaining. The disease usually is self-limiting and kind of disappears by itself. Now, I think I may have shown you this slide before. I want to just basically give you an overview of the complement system. So the complement system, which is responsible for AHUS, is divided into 3 common pathways. One of them is the classical and the lectin pathway, and the third one is the alternate pathway. The classic pathway is stimulated by antigen-antibody complexes. The lectin pathway is stimulated by microbial polysaccharides. Now, whenever the classic pathway is stimulated, there is activation of C1q RNS, which are basically proteases or MASP proteins of the lectin pathway. And what they do is they break down circulating complement factor 4 and complement factor 2 to give rise to a protein molecule called C4b, C2b. And this is also known as the C3 convertase of the classic pathway. Now, in the alternative pathway is kind of a different pathway. The alternative pathway is continuously working like a surveillance system. And in this pathway, C3, which is in the circulation in the aqueous phase, is acted upon by factor D, which in turn breaks down factor B into factor BA and factor BB. So C3 will combine with factor BB to form C3BB, which is also known as the C3 convertase of the alternate pathway. So it is important to note that there are 2 C3 convertases, right? We just say, oh, C3 or C5 convertase, but if you go into depth, there are actually two C3 convertases, which are quite different, yeah? There is the C3 convertase of the classic pathway and then of the alternative pathway. Now, these C3 convertases work on the circulating C3 molecule and break it down into C3A, which is a potent anaphylatoxin, which causes kidney damage, and C3B. Now, C3b in turn has various different functions. So it's an important molecule. Number one, C3b will combine with the C3 convertase of the classic and alternate pathway to form C4b, 2b, C3b, and C3b, BB, C3b, which in colloquial terms are also called the C5 convertases of the classic and alternate pathway. This C5 convertase works on C5 and breaks it down into C5a and to C5b9, which is also known as the MAC complex and is responsible for kidney damage. C5a, as I showed you last time, is the molecule which is responsible for ANCA vasculitis, and if you block this molecule, you can treat ANCA vasculitis. Now, C3b also plays an important role in the amplification loop, which means that once if you have C3b, then C3b amplifies this process of C3 convertase activation, and it results in further C3 production and further C5b9. And what is important to note is that this amplification loop is regulated by inhibitors. They are also known as regulators of the pathway. So these regulators are factor H, factor I, and MCP. So the promoters of this pathway are factor B, factor D, and C3, whereas regulators of this complement pathways are factor H, factor I, and MCP. So if we just step back and think, what factors will result in unregulated complement activity? So if you have an excess of factor B, factor D, or C3, you will have an increase in complement activation. If you have a decrease in factor H, factor I, or MCP, that will also result in increase in complement activation. So it's a bit complex pathway, but remember, I didn't make this pathway. I'm trying to simplify it. But in the literature, you will see a lot of these new drugs which are working on this pathway. So I thought that I would spend at least 5-10 minutes to clarify this pathway so that you are all aware how this pathway works and how we can block this pathway. So if I try and simplify it again, you have the three pathways which result in C3 activation, which then results in C5 activation, resulting in C5b9 and C5a, which then cause inflammation. The activators of this pathway are C3, complement factor B and D, and inhibitors or regulators are complement factor H, I, and MCP. Now, what kind of mutations will result in activation of the complement system? Now, we define these mutations into two groups. Now, if you have what we call as gain of function mutation in complement factor C3, complement factor B and D, then you will have excessive activation of the complement system. And if you have a loss of function mutation in complement factor H, Phi, and MCP, then also you will have unregulated complement activity. So it's a bit difficult to understand, but I can share these slides and you can go over this again. Therefore, a gain of function mutation in the activator pathways or a loss of function mutation in the inhibitor pathways will shift the balance towards unregulated complement activity, and thereby you get this TMA or AHUS process. Now, as I told you, there are different kind of genetic mutations in these complement pathways. They are caused in complement factor H mutations, complement factor I, C3, factor B, factor D. You don't need to identify the mutations to make a diagnosis of AHUS. Obviously, if you have these mutations or if you have family members who have a history of these mutations, then definitely it helps you to make the diagnosis of AHUS. But as you can see, in about 40% of the cases, there is no identifiable genetic mutation. So identifying the genetic mutation is not really needed for a diagnosis of AHUS, but definitely if you have an AHUS genetic mutation, it does help and it solidifies your case for an AHUS. AHUS also requires a trigger to unmask that genetic mutations. In about 2/3 or about 80% of the cases, as a clinician, you will be able to identify that trigger, which results in the phenotypic expression of that mutation as AHUS. But in 30% of the cases, you will not be able to identify that trigger. Regardless of the trigger, you will have complement activation and you will have end organ damage, which for us as nephrologists usually presents as kidney involvement. Now, as I told you before, the disease affects multiple organs. We usually see CNS involvement, which presents as confusion and stroke. GI involvement is also very common, and renal involvement, which if left untreated can progress to end-stage renal disease in more than half the cases requiring dialysis. Now, remember I spoke to you about the triggers. What are the common triggers which can stimulate the complement pathway? Well, the most common triggers are number 1, malignant hypertension, number 2, pregnancy, number 3, transplantation, number 4, medications, and then autoimmune disease, surgery, trauma, C-section, etc. And what is important to note that malignant hypertension by itself, even pregnancy by itself, can cause TMA picture, which can mimic AHUS. And they can also be triggers in genetically susceptible patients, which can cause an AHUS. So as a clinician, you have to identify if that patient with malignant hypertension presents to you with low platelets and kidney failure. You have to ask yourself the question, is my patient having TMA and atypical HUS-like picture because of malignant hypertension, which will resolve spontaneously once I treat the malignant hypertension? Or did this malignant hypertension serve as a trigger in my so-called still unidentified genetic mutation patient, which triggered the complement system, which will result in TMA/AHUS, which will ultimately proceed to end-stage renal disease. So in the past, we used to have patients who had malignant hypertension who progressed to end-stage kidney disease. And then we used to tell our patients, you know, your end-stage kidney disease is due to malignant hypertension. But now we know that perhaps the majority of these patients actually have malignant hypertension, which serves as a trigger in their genetically susceptible mutations, stimulates the complement system, and that is what is actually responsible for them proceeding to end-stage kidney disease. And it is not malignant hypertension per se that is causing them to have end-stage kidney disease. So this, I can elaborate this further over here. So here you see that this is a threshold for clinical presentation of TMA. In patients without underlying complement abnormalities, let's say they present with malignant hypertension and they do not have underlying complement abnormality. They may have some level of complement activation, some level of TMA, but it is a mild process which is self-limiting and does not manifest itself clinically. In some patients, the triggers such as malignant hypertension can present itself as a TMA, but these patients may not have underlying genetic abnormalities. when you treat the malignant hypertension, the TMA process resolves and it is self-treated or it disappears, and the patients tend to recover. Now, if you have malignant hypertension in a patient who has an underlying complement disorder with a genetic deficiency, then in these cases, the malignant hypertension is a trigger to activate the complement system. It manifests itself clinically as a TMA-like process. You treat the malignant hypertension, the blood pressure is well controlled. You would expect the TMA process to resolve by itself, but it does not resolve. The patients continue to have a background thrombocytopenia and a MAHA-like process. And these are the patients in whom you will suspect AHUS. And even without confirming that these patients have a genetic mutation, you need to start these patients on anti-complement therapy. Now let's look at an example. So, pregnancy is a disorder which can result in some level of TMA. But in its most severe form, this TMA presents as an atypical AHUS. So if a patient who is pregnant presents as a TMA-like process, that means they have thrombocytopenia, microangiopathic anemia, you suspect that they have a TMA process, you take the patient to delivery, and 48 hours after delivery, you would expect the TMA process to resolve. But if the TMA process does not resolve, then it should raise your suspicion that perhaps this patient has an underlying AHUS. So here you can look at all of the diseases in pregnancy which may present as a TMA. Patients with preeclampsia, eclampsia, or HELLP syndrome can usually present with a TMA-like process with thrombocytopenia, liver failure, some kidney involvement. We deliver these patients, and then we see a resolution of their TMA process. This is what normally happens. There are a small percentage of patients who have a TMA process. We suspect they have preeclampsia, eclampsia, HELLP syndrome. We deliver these patients, and you do not see a resolution of the TMA process. And previously, they proceeded to end-stage kidney disease. And a couple of years ago, we used to tell these patients, yeah, your kidneys failed probably because of eclampsia or HELLP syndrome. But actually what these patients had was an activation of their complement system, which resulted in AHUS, and then proceeded to damage their kidneys, resulting in end-stage kidney disease. So here you can see the time course of these diseases. Preeclampsia, eclampsia, HELLP syndrome, and TTP, all of them present with a clinical picture of TMA, usually in the prepartum period. You deliver these patients, and spontaneously within 48 hours, the symptoms resolve. But if you deliver these patients and the symptoms do not resolve within 2 or 3 days, then you should have a high index of suspicion that it is not postpartum eclampsia or just HELLP syndrome, which is causing their symptoms. You have to think about an underlying complement disorder like AHUS, which is causing all of their symptoms and problems. And you need to consider plasmapheresis, or if you have the new complement system inhibitors, like eculizumab or revilizumab. And the same thing is common in malignant hypertension. In malignant hypertension, it's like the chicken or egg. Did the malignant hypertension cause the patient to have kidney failure, or did kidney failure cause the patient to have malignant hypertension? Or the third alternative was malignant hypertension just the trigger in a genetically susceptible patient, which resulted in activation of the complement pathway, which caused him to have AHUS, and progressive end-stage kidney disease. So as a clinical nephrologist, you will have to identify those patients who present only with malignant hypertension, or you will have to identify whether malignant hypertension served as a trigger to cause this atypical AHUS. Now, there is no definite test to help you with this, but the clinical course of the patient, that, okay, I treated this patient for malignant hypertension, within a week or two, I would expect to see an improvement in their kidney function, an improvement in their platelet counts or the MAHA process. But if you do not see that, then you have to strongly suspect complement activation causing AHUS. So this is basically what I'm trying to explain to you, that you need to have an open mind when you have these underlying triggers such as pregnancy, malignant hypertension causing kidney damage. You have to figure out whether these causes are directly causing a TMA process which can be self-regulating, or have they opened up a Pandora's box where now the complement system is activated and now you have a self-perpetuating complement activation causing an atypical HUS. Now, just to highlight this, I have a case presentation. We had a 40-year-old Nigerian male who presented last year with malignant hypertension and renal failure. So in July 2023, I saw this gentleman for the first time, and he had a TMA-like process. Now, I attributed it mainly to malignant hypertension, mainly because I think there was a deficiency or gaps even in my knowledge. But I said that to myself, okay, he has a TMA-like process. I'm not going to do $1 million workup on him. I don't want to do genetic testing or testing for other diseases. It looks like a clear-cut case of malignant hypertension causing TMA and renal failure. I'll just order some ADAM TS13 activity because it's relatively cheaper to genetic testing, and the results will be available in 48 hours. So I decided to do it. I controlled his malignant hypertension, and the patient went home. Then in September 2023, he was readmitted with a AKI on CKD and a TMA process. Again, there was a mild improvement in his kidney function and with control of his blood pressure. But when he went home, he was followed up once in the clinic, and what the internist didn't pick up was that even at that time in the clinic, his platelet count was actually low and his kidney function did not return to normal. So that was an indirect clue that even when in the clinical setting, even when his blood pressure was well controlled, he still had an underlying TMA-like process, and that should have raised some red flags that perhaps this patient has a complement-mediated disorder going on at the same time. So in December 2023, while I was doing the inpatient consultation, this patient was readmitted again with TMA and worsening of his kidney function. You can see over here, this was his third admission, where he came in with a low platelet count, high serum creatinine, high LDH levels. So at that time, I just kept my mind open and I said, maybe he has an underlying TMA-like process with AHUS. So let me send out the genetic testing for him and let me just do a kidney biopsy. Now, the reason I did the kidney biopsy was not to confirm TMA, because both malignant hypertension can cause TMA and AHUS can cause TMA. So I knew what I would find on the biopsy was TMA by itself. So you don't need a biopsy to diagnose TMA process as such. You don't need a kidney biopsy to diagnose AHUS. The reason why I did the biopsy was because I said to myself, I need to find out with his serum creatinine of around 400, what is the level of interstitial fibrosis and tubular atrophy. Because if this patient had significant interstitial fibrosis and tubular atrophy, I do not want to give him a $500,000 drug from which he will have no benefit. But if the patient had mild interstitial fibrosis and tubular atrophy, then I thought that there is enough justification to present this case to the insurance provider that this patient has a TMA process, he has atypical AHUS, he has a biopsy which shows TMA, there is an absence of significant interstitial fibrosis and tubular atrophy, which kind of suggests that he has a complement-mediated disorder, and he would benefit clinically from getting a $500,000 drug in the form of eculizumab or ravulizumab, and in whom we can expect a recovery of his kidney function. We also did some testing on complement levels. You can see that C5b9 was a little high. It's not very high, but it's still on the higher side. I have seen levels of around 1,000. But it does tell you that if the C5b9 is elevated, then there is an alternate pathway complement activation. And that once again indirectly suggests that there is complement system activation going on. We also did genetic studies on him, and this patient had a genetic mutation, homozygous deletion in complement factor HR1 and complement factor HR3. And the homozygous deletions are actually quite severe phenotypic manifestations of atypical AHUS. Just to proceed quickly, as I said, there are a lot of triggers, and transplantation can also be a trigger, yes? So patients can present in different ways. Patients can have AHUS leading to end-stage kidney disease, and then they have a kidney transplant, and that kidney transplant can again have a recurrence of AHUS. Patients who have never had AHUS before undergo a kidney transplant, and then they can get AHUS either because of infections, they can get CMV infections, or medications like tacrolimus, etc., can manifest as atypical AHUS. So transplantations by itself can lead to AHUS. Infections in transplant can lead to AHUS, and medications used in transplant can also lead to AHUS. Regardless, if patients with AHUS present with patients with if you look at the renal prognosis of patients with AHUS, the prognosis is quite poor, with 5-year renal survival is only about 50%. Renal survival is better in pediatric patients. In terms of kidney transplant, patients who have a kidney transplant with a previous TMA manifestations and no subsequent TMA manifestations after the transplant, even those patients, the 5-year survival is 70%. And after transplant, if they do, however, have TMA manifestations, then the 5-year renal survival is even worse at around 36%. Okay, and finally, I just want to increase your awareness that most of these TMA patients are quite sick. They present with oliguria, CNS, GI involvements, and they're usually picked up either on the floor in a very sick condition, or they are picked up in the ICUs where they present with malignant hypertension and they're admitted for IV antihypertensive medication. So we need to increase the awareness of our patient ICU physicians about TMA and atypical AHUS. Now let's look at the treatment. So previously I had told you that unregulated activity of factor B and factor D or C3 can cause atypical AHUS. So now we have inhibitors of complement factor B and D, which is iptacopan and danicopan, and we have inhibitors of C3, which is pegcetacoplan. Potentially, all of these drugs can be used for treatment of atypical AHUS. We also have C5 inhibitors such as eculizumab and ravulizumab, and we have more data on this. And AstraZeneca has basically taken the lead on treatment of atypical AHUS. So more or less the standard of care for atypical AHUS is complement factor 5 blockers, which is eculizumab and ravulizumab. The iptacopan is produced by Novartis, and pegcetacoplan is produced by Absobi. They have taken a different path. They are focusing mostly on IgA nephropathy. They are focusing on PNH, and they are focusing on C3GN. They're not doing studies on AHUS, though they are quite effective. They're not doing trials on AHUS because this market is kind of captured by AstraZeneca and their products, eculizumab and ravulizumab. So previously we were using a drug called eculizumab, which has to be given every 2 weeks as an intravenous infusion. But now we are using the new product, which is known as ravulizumab. The benefit of ravulizumab is that ravulizumab is a complement factor 5 blocker. And it is long acting. So we give it every 8 weeks. So instead of giving 26 injections in a year, we only have to give 7 or 8. So here you can see that when you inject eculizumab to a patient, it binds to circulating factor 5, complement factor 5, which is one of the end pathways of the complement activation. It is taken up into the cells. It forms into the endosomes. And there it is broken down by the lysozyme. So you have a deactivation of complement factor 5 with eculizumab. Ravulizumab is slightly different, where after binding with C5 within the endothelial cells, once in the endosome, it kind of separates from the complement factor 5 and then is once again released into the circulation, where it further binds to C5. So it has a longer half-life. Obviously, every time, not all of it is released into the circulation. Partially it's released into the circulation, but nevertheless, a majority is released. And it has a longer half-life of about 8 weeks. And you can see that as soon as you inject ravulizumab, you can see that within a day or two, the complement factor 5 levels have decreased. You can see the response of the patient within around a week. You can see that the platelet levels are going up and they are sustained. You can see that the LDH levels are dropping immediately, and you can see that the patient's eGFR is also improving. Even patients who are on dialysis because of AHUS, if you do a biopsy, as I told you, you don't need a biopsy to confirm AHUS, but if you do a biopsy and it shows that all of these lesions are acute and there is less IFTA, and even if these patients have ended up on dialysis because of severe inflammation, if you give them the drug ravulizumab, there is a reversal or improvement in the kidney functions, and these patients with acute lesions can come off dialysis. So the eculizumab and ravulizumab are still recommended even on patients who progress to end-stage renal disease requiring dialysis. And here you can see that the old product, which is eculizumab, we were giving around 26 injections. The patients had to come to the hospital every 2 weeks, whereas with the new drug, ravulizumab, it's much easier. We give them only around 7 injections a month. So yes, it is a bit more expensive, but the overall cost is much less. Now, the question is, how long do we give this therapy? We know that these patients have an underlying genetic mutation, and sometimes there is a recurrence of the disease. What is important to note that certain genetic mutations, especially the mutations of complement factor H, have a high incidence of recurrence and are very severe. So perhaps you need to give them either lifelong therapy or at least therapy for at least one year or so before you can contemplate stopping these drugs. But if you have an atypical AHUS caused by a milder genetic mutation, such as complement factor 5, and it was triggered by, let's say, an infection, then maybe a shorter course of about 3 to 6 months would be enough to control this atypical AHUS, and then you can taper and stop this drug. So the duration of therapy actually depends upon the trigger as well as the type of genetic mutation that you had. And if you are thinking about stopping this medication, then you have to keep a close eye on these patients. You need to monitor their labs and you need to monitor their clinical condition, whether there is evidence of TMA process recurring, patients are having GI symptoms, or if there is a drop in their platelet counts, or there is an increase in their LDH, etc., then you need to stop that process of discontinuing or tapering the eculizumab or ravulizumab, and you need to keep them or restart them on these medications. And I think that would be it for now. So if you have any questions, I'm open to it. Thank you.
Oh, thank you, Dr. Dastoor. That was quite an enlightening discussion topic. And it's quite a complex one, which you have put in in a very simple way, especially breaking it down. It was quite interesting that I'm seeing there's a relationship between preeclampsia, then HELP syndrome, and then activation of the complement pathway, leading to a typical HUS, and even other causes like drugs, malignant hypertension, and the likes.
Yeah.
Maybe on my side, if I can just ask a quick question. In terms of treatment, I've seen there's a lot of investment that has been done by big pharma companies to develop some of the novel therapies for this. And I've seen that some of the treatment regimens go for, I think, a minimum of 6 months. And I just wonder if this is truly a rare condition and a lot of investment has been put there, probably the costs are quite high in terms of treatment costs. I don't know how this is it really affordable, especially for the African population, or a cohort where most people are insured and might need even treatment for more than 6 months or so.
Yeah, that's a very good question. So, I think you have to do your health economist will have to do a cost benefit analysis, cost effectiveness evaluation. So what we have seen is, for us, the cost of dialysis for 1 year is about $100,000. When you add on the cost of admissions to the hospital, changing catheters, lines, infections, etc., that cost per patient per year goes up to around $130,000. Now, if we treat these patients, at least in Abu Dhabi, and we can avoid them on going to dialysis, then it kind of justifies, the cost does justify treating these patients. Now, you have to apply the cost benefit analysis to your own country. Each country has to do this economic evaluation and then come up with a price point and decide whether this treatment is justified or not, So it's very difficult for me to talk about Africa, but at least in the UAE, which is a high income country and where the cost of dialysis per se is high, I can easily justify using drugs such as iptacopan, pegcetacoplan, avacopan, as well as eculizumab and ravulizumab. So for us, I really don't get into discussions because it's very easily justifiable. So I think you would be best, able to answer the question for your environment as such.
Thank you for that. I think we leave it to the health economists
Yes.
and policymakers to make that decision. But thank you. That
Though
was
I can tell you, just from my experience, I know that now there is a generic form of eculizumab, which is available and made in Russia. And I heard it is about 10 times cheaper than the original product from AstraZeneca. And me, myself, I would have no hesitation in using that, okay? Having said that, I also want to say that we have used the other complement blocker, pegcetacoplan, in patients with C3. We are paying approximately $4,000 per injection, and it is 2 injections a week. So my insurance company is paying $8,000 every week for that patient's treatment. My brother-in-law was in India, and he told me that this drug is available in India, pegcetacoplan, for PNH, and it is available at 1/10 the cost as it is available in Abu Dhabi. But even 1/10 the cost for an Indian patient is a relatively high, $4,000 per injection in Abu Dhabi, $400 in India. $400 in India is a very exorbitant price, for this drug.
Yeah, agreed. I think there is a part you mentioned, $8,000
Yeah.
a week. That's
Yeah,
quite a
$8,000
lot.
a week. It's ridiculous. But if
Yeah,
it saves, if a 12-week course is able to kind of reverse the C3 glomerulopathy and take that patient away from dialysis, then it is still able to justify, the way, you have to remember the pharma companies are not stupid. They have done a lot of analysis. They know each particular country, what cost these countries are able to bear, and they know the cost of dialysis. They have done their homework, and they know that it is justifiable to put these stupid prices in these high income countries and to intentionally put much lower prices in low income countries, so there's no way around it. They've done their work, and we have to work with them.
Great, thank you for that. If I can just take a question from the Q&A. There's a participant, not sure if the name is Transplant One. He's asking about post-transplant TMA. What is your experience in practice? I think in practice, in the management of post-transplant TMA.
Yeah, I don't have a lot of experience in post-transplant. We have a transplant team, but what we have seen is that the patients who have, now we have a new kind of protocol where patients who have an unexplained renal failure, we try and do genetic testing on them. And if the genetic testing confirms a complement deficiency, then we are starting these patients on these drugs at the time of transplantation and continuing these drugs for at least 6 to 12 months. If they have a confirmed AHUS and they are going for a transplant procedure, then obviously they are started on these medications at least for 1 year duration. And complement factor H is probably one of the most virulent genetic abnormality, which will definitely require eculizumab therapy if you want to prevent recurrence. Also, in transplant patients, it may be better to get a non-living donor as such. There is a lower risk of recurrence with a non-living donor. And if your patient had a very rapidly progressive clinical course, then also they have a worse prognosis post-transplantation. So that's what I can tell you.
Thank you for that response. A question from Datonya Briggs is asking, have any clinical trials been done in adolescent or children with atypical HUS?
Once again, I don't deal, but my pediatric nephrologist, they have seen much more cases. They have just published a series of 30 patients with atypical AHUS. These complement deficiencies and these disorders are more common in younger children. Many of them, once they reach their adolescent and adulthood, they are transferred to our care. But by that time, they have already had all the workup and testing done. So we don't play an important role in their diagnosis or treatment as such. What we are seeing now is because of increased awareness. Previously, what we used to just say that, oh, this patient had malignant hypertension as a cause of his end-stage renal disease. When we keep an open mind, we do genetic testing, perhaps do a biopsy, etc. or do this complement workup, we are picking up more cases of AHUS, where in the past we would have just said, oh, it's just malignant hypertension. And these are the cases where we are picking up. So in the last 2 years, I've had about 3 cases of atypical AHUS, which is caused by genetic mutations resulting in a complement disorder. I have had HUS due to the usual Shiga toxin. I have had TTP cases related to pregnancy, and I have seen at least 2 or 3 cases of pseudo TMA, which is basically TMA or AHUS caused by vitamin B12 deficiency, where these patients presented with atypical AHUS like clinical picture. Vitamin B deficiency was diagnosed because they had some parietal cell antibodies. And immediately after giving them vitamin D, within 3 days or less than a week, there was a complete reversal of this TMA process. So there was no need also to give them any expensive medications. Yeah, so I think you need to keep in mind about vitamin deficiency as well, vitamin B12 deficiency.
Great. I think related to the last bit of your response, another attendee is asking, in the absence of these drugs, can we use steroids and plasma exchange? I think because of the costs.
Yeah, and I think that's what we used to do in the past, you know. So if you had a trigger, let's say the trigger was infection, you treat that infection, um, um, not, I wouldn't say GI infections, because if you have an STAC HUS, you don't really need to do plasmapheresis. The disease is usually self-limiting, and you treat the GI infections. But if you have an infections like Streptococcus, CMV, you treat those infections, and you start the patients on plasmapheresis, etc. And then they usually have a spontaneous resolution of the disease.
Thank you for that. I believe a participant by the name Dr. Tahani is asking are there other causes of impaired ADA MTS 13 rather than TTP?
I'm not aware of it. I usually link ADAMTS13 deficiency to TTP, but you can also have antibodies to ADAMTS13, which can cause, I think, as far as I remember, yes, the questionnaire may be right. There are also other causes, other diseases associated with ADAMTS. I'm not exactly sure off the top of my head, because TTP is usually a hematologic disease. I think a hematologist would best be answered. From my perspective, I usually correlate ADAMTS13 deficiency with TTP. And nowadays, previously, we used to also give them plasmapheresis or plasma exchange, but now we have a new drug available, caplizumab, which is 1 Willebrand factor kind of, I think, replacement therapy, or ADAMTS13 replacement therapy. And our hematologists are using that for treatment of TTP.
Participant called Anna is asking, in pregnant women after delivery and when TMA persists in countries where eculizumab and ravulizumab is not available, what else can be used?
Well, then your best hope would be to consider maybe steroids, number one. You can do plasmapheresis. You can consider mycophenolate, mofetil. You can even think about rituximab, but I'm not sure whether those would be the right treatments. These have all been tried, but it hasn't been proven to be effective, you know. The only actual studies which we have are on complement factor 5 inhibitors, showing the efficacy of eculizumab or ravulizumab. But in the past, that's what we used to do, you know. We used to do plasmapheresis and pulse steroids, mycophenolate, rituximab, just blindly throwing something which will blind the immune system and hoping for the best. But now you have more specific therapies So that would be the right way to go, for treatment of this, because you know the cause of the disease and you have the specific treatment for the disease. I would say rather, uh, what would I wouldn't say what are the other therapies, but rather now I would be looking at which complement inhibitor pathway would you consider blocking as the best therapy? Would you consider C5 blockage as the best therapy, or C3, or factor B, or factor D? That would be the question to ask in the future. If somebody is not responding to eculizumab, then what do you do? So then you would probably go higher up in the pathway and block C3, and consider giving them pegcetacoplan, because you can get resistance to eculizumab, the pathway, because once you block C5 by a negative feedback loop, there is an increase in C3 levels, and that may overwhelm C5 blockage by eculizumab. So, if you have resistant AHUS, then you may want to consider using a C3 blocker like pegcetacoplan, or factor B blocker like iptacopan, you know. But as I said, these are expensive therapies, and in challenged countries, yeah, you can try MMF or rituximab, plasmapheresis, plasma exchange, etc.
Thank you for that. Another question asking how soon can TMA recur post kidney transplant, and is there anything that can be done to
TMA,
prevent
TMA,
recurrence?
TMA can recur within a few weeks, and in fact, in early biopsies, you can see early changes of TMA happening. But clinical manifestation may take few weeks to few months. As I told you before, some genetic mutations like CD46 mutation, so-called thrombomodulin mutation, are quite milder, and they may not recur in the transplant. But complement factor H, especially in its homozygous presentation, may have an earlier and more severe presentation in the transplant.
Thank you. Participant by the name Rehema is asking, are there cases in a typical HUS where plasma exchange therapy is contraindicated?
I'm not really sure, unless the patient has a contraindication to plasmapheresis itself, some kind of immune reactions or something, or maybe I can't really think of anything else, or the person has an active infections, because plasmapheresis increases the risk of infections per se. Then you may want to think about holding off on the plasmapheresis. But if you can't do plasmapheresis, then you can always try and do a plasma exchange in case of plasmapheresis.
Thank you. I think the other question from Dr. Anthony Giunda, I think you had answered in regards to alternative cheaper medications for poor patients who cannot afford. I think you had tackled that. So last question from Dr. Ben Lomatayo before I give it to Dr. Lloyd to just answer to ask his question live. Dr. Ben Lomatayo is asking how frequent in your practice do you see a typical HUS?
I can tell you now that 2 years ago, I wasn't seeing atypical AHUS. As I said, there were knowledge gaps. We weren't attuned, our mind wasn't thinking about these complement disorders. But recently, I don't know whether to blame the drug companies or to thank the drug companies. They increased our awareness, and probably it benefits them a lot. But yes, after that, we are seeing a lot more of atypical HUS. So as I told you, I have seen at least 3 or 4 cases of confirmed genetic mutation induced complement-mediated atypical AHUS, and I have seen atypical AHUS caused by other causes like vitamin B12 deficiency, drug-induced atypical AHUS. So just that awareness has increased our overall pickup of both TTP and atypical AHUS.
I think I'll now give it over to Dr. Lloyd
And
to
sorry,
answer.
one more question. And you have to remember, in Abu Dhabi city, we have a population of about 2 million people. So in the last year, only in our hospital, if we picked up 2 cases per 2 million, that would be about one case per million. So it's a good pickup, I would say. As I showed you before, in the US, the number of cases is about 1 or 2 per million population. I'm sure that in other hospitals in Abu Dhabi as well, they have picked up at least 1 case per year. So I think the awareness is increasing, and I think the actual incidence and prevalence of the disease is probably higher, but I think we are missing a lot of these cases.
I agree. I think more awareness is needed so that we're able to pick more cases. Lastly, I'll give it to Dr. Lloyd. Dr. Lloyd, you can ask your question live, Dr. Lloyd, or I can just probably let me read it out for him. Maybe he has a poor network coverage. So Dr. Lloyd was asking, would a graft from a patient with genetic complement deficiency be picked up post-transplant when the patient is negative for genetic complement disease?
Hello. It's a phenomenal presentation.
Thank you. You're welcome. So the question was, would a graft...
Thank you very, very much, Dr. Dastoor. Question is like, when you have a transplant, a post-transplant HUS, atypical HUS, it's very interesting. I mean, the first time that, I've learned so much about atypical HUS and the complement mediated,
So
atypical HUS that you will see, and treatment, if the presence of IFTA, the absence of IFTA. So now when you have a transplant, post-transplant, you've done a genetic testing.
Genetic testing in the recipient?
Pre-transplant, which shows that your and the donor have a the graft kidney can have a genetic component to it and have a HUS. I mean, I know it's an odd question, but then again, is there a role for a kidney biopsy and genetic tests of the material that you take from the biopsy? Do you think that would be of any benefit in that sort of situation? It's a very rare situation, but it's interesting. That's why I asked you.
Yeah, I wouldn't be sure, but I think if you have such a patient where the donor graft is from a patient who has a mutation, and as I told you, if you look at the total mutations, they are quite common, about 10% of the population, and you may be actually transplanting a lot of patients in whom you are unaware that they have a genetic mutation. But in such cases, if you knew that they had a genetic mutation, that shouldn't stop you from them being donors. But I think in those cases, if the recipient does get a transplant, and if he shows evidence of TMA or unexplained renal failure post-transplant, then you have to keep in mind that perhaps is there any activity in this disease, etc. Having said that, if the recipient doesn't have a genetic mutation per se in the recipient, then I'm not really sure whether getting that transplant from a donor with that mutation would cause the disease. So that's kind of like a gray area, and I don't think it has been even picked up in the literature. But what I can tell you is we will be transplanting a lot of patients where the donors do have an underlying genetic mutation.
Yeah. So this is like, I mean, what I mean is like a graft limited TMA, atypical HUS, graft limited. So that
we have seen that. We have seen a lot of those cases where the TMA is limited itself to the graft, and they do not have any other systemic manifestations, and then we treat them aggressively, with these kind of patients.
So there, do you think that there's an indication to do a biopsy and check the biopsy material for genetic mutations? I mean, I know it's out of the question.
Yeah, if you have the resources, and I know in some centers in the US, in the Mayo Clinic, their pathologist there, Dr. Sethi, is doing such testing. We per se, even in Abu Dhabi, we don't have the facilities to do the testing on the graft itself.
Yeah, yeah. Oh, wow. Okay. Right. Okay. But then,
Now,
okay.
you know, the slide also, I just wanted to point out, you mentioned that TMA and looking for IFTA. So this
Yeah,
is just from my experience, yeah.
yeah,
Um,
yeah.
we have
I agree.
treated
Yeah.
patients with C3,
Yes.
you know, expensive medications, and we have had bad prognosis. And
Yeah.
there's not a lot of literature out there on C3, you know, trials of
Yeah.
C3 are done
Yeah.
with 12 patients, 15 patients, and the drugs are being FDA approved. So, you know, the C3 is a very rare disease. So we were the first center in the world to use pegcetacoplan in a non-clinical trial setting for C3 glomerulopathy. And our patient actually had a poor outcome. He didn't respond to it. But what we learned is doing a biopsy and rebiopsying C3 and diseases like AHUS is very important because the IFTA can progress very quickly. Within a period of 2 to 3 months, you can go from 10% IFTA to 90% IFTA, you know.
Oh, okay.
So these patients need a close follow-up. And even though the literature doesn't focus on biopsies, etc., repeat biopsies, I think when you're using these expensive drugs, you really need to make sure that your patients will benefit from these expensive drugs. And one way to look at the potential benefit would be to do a biopsy and look at, you know, the level of acute inflammation and the level of chronic fibrosis to help you guide you whether these drugs are effective. Otherwise, you'll just be throwing money down the drain, you know. And a lot of these drug companies and pharma and studies don't mention all of this, maybe for some ulterior motive. But I think this is what at least I learned from my experience.
Yeah, that's a very important point. Very, very important practical point because
Yeah.
money is extremely important patient-wise, and whatever we can save in terms of economic analysis, yes, but you know, whatever we can save, and when we see that it's futile spending that much of money when the graft
You
is
know,
not there. Yeah,
even one patient for these drug companies is like a financial boom to them, you know. These companies will jump over themselves just to get one patient. So, you know, you have to really be very ethical and
yeah,
really try and identify the patients whom you think will benefit. You know, this patient, we were very over keen to treat him, and he was having a rapidly progressive course and
yeah,
for C3 GN, and he went from a creatinine of 300 when he
yeah,
had an of 20%. We started him treatment 3 months later when his creatinine was 600, assuming that he still had the same level of IFTA but just more aggressive lesions. And we started him on pegcetacoplan. After 1 month, he didn't improve. We did a biopsy, and by that time he had 90% IFTA, you know. And these were good biopsies with 4 cores and 80 glomeruli. So it wasn't like a sampling error, you know. So that just shows that these diseases are very active, very progressive. You need to keep, you know, following these patients more thoroughly and doing frequent biopsies, at least if you're going to start these treatments, especially when they have rapidly worsening creatinine. You need to figure out, is this worsening creatinine from IFTA or is it a progression of his acute lesions, you know, and then decide on therapy, expensive therapy for these patients.
Now, on your genetic testing, do you have a stratification of genetic mutations which are very much more high risk as compared to just high risk?
Yeah, you know,
Is there,
that's a good question, and the question is, how do you figure out? The report usually comes back as variant of unknown significance, and could be non-pathogenic. Variant of unknown significance, what that means is this mutation in the gene has still not been identified. So the American Association of Genetics, or AAGM, will collect this information, and if more cases are collected, then this variant then transforms itself into variant of known significance, you know. So what they are doing is collecting all of these new mutations from all over the world And then slowly, as more mutations are known, the variant of unknown significance becomes a variant of known mutation. The homozygous mutations are more virulent than the heterozygous mutations. Complement factor H, complement factor HR5 are more virulent than other complement mutations, like CD46 or something, So yes, you are right. There are some mutations which in general are more virulent and need more longer treatment than some other mutations.
Thank you very much, Dr. Dastoor. It was a phenomenal session. I mean, you covered the TMA, the characteristics, the diagnosis.
Sure. Any other? There is one question.
TMA,
Any comments?
TTP, Shigaleklan, BMP, drug, autoimmune, the whole work. Wonderful language.
Sorry, I was
so
just saying, any comments on E. coli, UTI, and AHUS? That's a good question. I haven't encountered E. coli, UTI causing AHUS.
Sorry, I didn't get you. Sorry. Any comments on?
No, there is a question, an interesting question.
In the chat
Ask
box, yeah.
E. coli, UTI causing AHUS. And as I was saying, I have not encountered E. coli, UTI causing HUS. The only AHUS I have seen is with Shiga toxin associated HUS, But I'll keep an open mind, next time, if there is an E. coli and the possibility of E. coli, UTI causing HUS.
Great, thank you for that. I think Professor Bima has his hand up. Professor Bima, you can unmute and ask your question.
Thanks so much, Yuri. I just two things, Dr. Dastoor. I just want to go back to that question that Dr. Lloyd asked you about, the donor having a mutation in the complement pathway, and you're giving it to a recipient who is normal. From my understanding, complement is produced by the liver, right?
Yeah.
So if the donor has a mutation, that is an abnormality of genetics, which is it's mainly in the liver. If you transplant in the kidney, then the chances of that mutation causing any problem is going to be very, very unlikely, because the patient's got a normal liver and producing complement. You know what I mean? Am I right?
Yeah, the complement per se is in the liver, right?
Yes. The mutation that the patient is transferring to the donor, I mean, we're transplanting the kidney. So that is not going to be transferred, because he's got a normal liver, which is producing normal complement.
No, I understand. The complement per se is produced in the liver, right?
Yeah.
But what I'm trying to say is what triggers this complement, the complement activation is not like per se a liver disease or per se. It is the fact that you have within your system a genetic mutation, and you need a trigger. And once that trigger is activated, then the liver starts producing, So you don't need to have like a liver problem as such. What you need basically is a genetic mutation, and you need a trigger. Now, if the donor has that and you transplant it into the recipient, you're not transferring that genetic mutation to that recipient, right? Per se, you're not transferring that genetic mutation into the recipient. So you wouldn't expect the recipient to have that, disease,
Yeah.
But on the other hand, if the recipient had that disease, then regardless of what you transplant that patient, there is a good chance that that recipient will again develop post-transplant AHUS.
That means the recipient has to have it, not the donor.
Yeah.
Right? So
exactly.
That brings me to an anecdotal condition. And just to answer the question about what's alternative available therapy in low middle income countries. So I had a patient who is of Caucasian origin, who was from the Afrikaner population, and she had features of hemolytic uremic syndrome. And initially I thought it was sugar toxin associated, because she had eaten some takeouts and she had a diarrheal illness, etc. but she had persistently low complement, wasn't responding. And so I did manage to get some genetic testing done, and she actually had a membrane cofactor complex
Yeah, MCP.
mutation. Yeah, MSc.
MCP.
And fortunately for me, I had a colleague in Northwestern University, was a friend of the CEO of AstraZeneca. So we managed to get eculizumab on compassionate grounds for a few doses. But then, of course, when the eculizumab dried up, she developed recurrence of the disease.
Yeah.
So we did plasmapheresis and everything else, but of course, the disease is not going to go away. That's a temporizing procedure. You know what I mean?
Correct.
So eventually, I had to send her up to Joburg, and what we did was a combined liver and kidney transplant.
Yeah.
So that she has normal complement, orthotopic liver transplant, so that she has normal complement formation, and then we did the kidney transplant, so the chances of recurrence of the disease in her will decrease. Have you ever tried that?
Yeah, they used to do that, and actually this was promoted mostly in Italy by Professor Remuzzi. So previously they were doing a lot of liver and kidney transplant. In our transplant center, for patients who have had AHUS, they are doing kidney transplant, but they're not doing combined liver and kidney transplant. What we are doing now is giving these patients eculizumab and giving them the kidney transplant. After a year of treatment, what we are doing is trying to taper off the eculizumab or ravulizumab. So instead of giving it every 2 weeks, we give it every 4 weeks, and then every 6 weeks and every 8 weeks. During this time, we closely monitor the patients. We check their LDH, we check their platelets, etc. If the patient is responding well, there is no recurrence activity, then we try and stop this medication in them. But if the patient does show some signs of recurrence, then we immediately put them back on eculizumab, and then we continue eculizumab for lifelong in these patients.
That's it. I was just trying to work out, in low middle income countries, what we can do, because the cost of
So yes,
eculizumab
previously, yes,
prohibitive.
you are right. There was when these drugs were not available, the only option would be to do a combined kidney and liver transplantation, and that was what was being done mostly in Europe and the US.
But thank you very much for that very enlightening talk, Dr. Dastoor. Really appreciate it. Thanks. Thanks, Yuri.
No problem.
Thank you, Professor Bima. Thank you, Dr. Dastoor. I don't want to close out Dr. Ben Lomataya. I think he wants to ask a question as much as we are the talent. Dr. Lomataya, you can unmute and ask. I think he is left, maybe has dropped off, but I think now just allow me to close. I want to say again, convey my thanks to Dr. Dastoor for making time. I think he is always available when he is called upon. And we appreciate that he always handles very complex topics, and they're quite enlightening, and we have learned a lot from this topic, as we have from many others. And on behalf of Africa Healthcare Network and our panelists, we wish you a good evening, and thank you again, and wish to have you again in future. Dr. Dastoor.
No, anytime. Thank you.